So I thank you all for being in our grand rounds today on this beautiful spring day in the Twin Cities. It is sunny, it is nice, really nice to be outside. Today we have our guest speaker who is known to all of us, Dr. Czyzzyk. A brief introduction about Dr. Czyzzyk. He received his medical degree from the Medical University of Warsaw in Poland. He then came to the United States as a postdoctoral research fellow at the Division of Rheumatology and Immunology at the University of North Carolina. He then joined the Anatomic Pathology residency program at Yale New Haven Hospital. After his residency, he stayed on for a 2-year fellowship in renal pathology, and later on as an associate research scientist, then an attending pathologist in the Division of Renal Pathology. Dr. Czyzzyk moved in 2010 to the University of Rochester as an assistant professor in the Department of Pathology and later as an associate professor. We all know and probably worked and interacted with Dr. Czyzzyk. He's a renowned scientist. Throughout his career, he has kept very impressive external funding. He's very well published, and obviously he's very interested in teaching and training of our residents and fellows. We are glad to have you with us, Jan, today, and back to you.
Thank you, Dr. Khalifa. Thank you, everyone, for joining me to tell you a little bit about research. So, as Dr. Khalifa mentioned, on the clinical side, I'm a renal pathologist. On the research side, I'm pretty much focused on something else, which is trying to understand how we can develop new therapies in diabetes. For the most part, I am focused on type 1 diabetes. And specifically, more recently, we became interested in the problem how we can create new pancreatic islets and how we can exploit the role of intrinsic protease activity in the pancreas for that purpose. And I think before I jump into specifics about the experimental design and findings, I thought it would be nice to go over just basic facts on diabetes. So as we all know, there are obviously these two types of diabetes. There are others, but for the most part, we'll focus on type 1 diabetes, and I will mention also type 2. So in terms of autoimmune diabetes or type 1 diabetes, we think that the initial event that triggers disease process is alteration of beta cells that produce insulin in the pancreas. And what causes this alteration is unclear. Some people favor viral hypothesis, but also it could be a drug or metabolic stress. At any rate, at some point, it is thought that neoantigens or neopeptides are being, or hybrid peptides are being formed, which are novel autoantigens that haven't been seen by immune cells before, and therefore that triggers initial autoimmune response and eventual over some time, that autoimmunity leads to destruction or almost complete destruction of beta cells. So to the left, you can see an example of a mouse islet, which is in the process of being destroyed by intense inflammatory infiltrate consisting of T cells for the most part. This is a mouse picture. In humans, we think a similar situation may occur, although it's a little bit controversial because the autopsy studies reveal that the level of inflammation is not as high as in the mouse models. So these mouse models, of course, represents partial artifact. Having said that, there is strong evidence that type 1 diabetes is indeed autoimmune condition. This evidence consists of observations that immunosuppressants can alleviate the disease process. There are these autopsy, biopsy studies showing that there is some low level of inflammation in the islets. Patients have auto-antibodies to islets. So it's, I think, compelling evidence to suggest that autoimmunity plays an extremely important role in type 1. Situation in type 2 is different because it has been thought for many decades that insulin resistance is really important early event which leads to secondary changes in beta cells consisting of the hyperplasia, and within several years from the disease onset, patients become insulin dependent. So there's also beta cell failure that happens in type 2. And the net outcome of pathologic changes in the islets is a scar development in the islets. So I guess the question is, why do we have type 1 and type 2 diabetes? And I thought when I was preparing to this seminar, I thought, okay, that maybe we should look backwards, far backwards at the history of human race. So many thousand years ago, we were all fit. We're good hunters and good runners. And of course, the food supply was pretty low. So people had to develop all these hunting skills and physical skills to hunt the wild beasts like the one shown in this image. And so in order to keep the blood glucose high, which was a precious commodity in those days, people developed two mechanisms. The first one was insulin resistance. The second one was to limit mitotic activity in beta cells, to kind of limit output of insulin, so that these two mechanisms allow to keep glucose relatively high in the blood, which is, of course, the main energy source for the brain. However, once humans learn how to cultivate the land and settle and start moving around, the insulin resistance as well, this poor mitotic activity of beta cells became culprits of diabetes. So diabetes is really, of course, a huge health care problem in our society. These are some basic facts about it. And the numbers are staggering because some 40 years ago, there were about 100 million people with diabetes. Now we have about over 400, but it will be coming up. And according to predictions, in about 20, 30 years, there will be 200 million people more with diabetes. Just in the United States alone, we have over 30 million people with diabetes. Not to mention almost 90 million of individuals have pre-diabetes associated frequently with obesity. I talked about type 1. Type 1 accounts just for a small fraction, 5 to 10%. In some countries like Norway or Finland, up to 20% of all diabetes is due to type 1. And as I mentioned, in addition to type 1 and type 2, there are other types. One which is kind of interest to our lab is so-called latent autoimmune diabetes of adults, LADA in short. This is, I think, interesting and a little bit underdiagnosed form of diabetes, because those folks usually are initially diagnosed as type 2. However, first of all, they are in their mid-30s to 40s. They present as type 2 clinically, so they do not require insulin for therapy. However, they are positive for at least one or more, but usually it's one islet autoantibody. And importantly, they progress to insulin dependence within a matter of several months, weeks to months. So it's a kind of smoldering, mild version of type 1, if you will. Some people call it even diabetes type 1.5. But what is important is that up to 10, in some countries it is believed up to 15% of all type 2 is LADA, so that may account for up to 50 to 60 million people worldwide that have this condition. So what is the problem that we are trying to address? This is the picture of Dr. George Eisenberg, who was the director of Barbara Davis Diabetes Research Center in Colorado. And he believed that in order to develop a successful therapy against type 1 diabetes, you need to develop a combinatorial approach, which would consist of, first of all, suppressing autoimmune response. Second, we need to deal with non-specific inflammation, which can be toxic to beta cells. And finally, we have to do something about islet biology and improving beta cell renewal. So this is mind-boggling that beta cells do not proliferate. And if you think about other components of the GI system, hepatocytes, enterocytes, these cells have very high potential for proliferation, whereas beta cells lack this potential. Having said that, there are attempts to overcome this bottleneck, and we heard in December of the last year from Dr. Garcia Ocana and his collaborators that there are promising methods to overcome proliferative block in beta cells. So one approach to address the problem in type 1 diabetes is to stimulate either production of new insulin cells from other cell types through transdifferentiation or from stem cells. Alternatively, to stimulate renewal of through enhanced proliferation of existing residual beta cells. The second approach to type 1 diabetes is, of course, to use immunotherapeutics, and one of the success stories is accomplished by Kevin Harrell at Yale and Jeff Bluestone at UCSF and many others investigators who showed in clinical trials that anti-CD3 therapy can postpone diabetes by about a couple of years in people at high risk. So there is some promise, but of course, a combination of these two approaches would be probably ideal, and maybe some other methods as well should be incorporated. So the problem is that these approaches are dependent on targeting the distinct molecular pathways and consequently require the use of reagents with equally distinct target specificities. So the logistics of developing commercial ways of treating type 1 diabetes are for that reason pretty high. So we became interested in the problem of beta cell replacement or renewal by making an observation on, which I will mention in a second. I just wanted to show before that a picture of the pancreatic tissue. So you can see that there are these clusters of endocrine cells, which we call islets of Langerhans. And what is interesting that some, not all, but some islets grow in a very close proximity to the pancreatic ducts. And I don't think this is just coincidence, because if you think about the developmental biology of the pancreas, all endocrine cells stem from the keratin-positive epithelial cells. So this proximity of these two different tissue compartments may be a reflection of what happens during embryogenesis. So in collaboration with Octavian Henegari at Yale University over 10 years ago, we worked pretty hard to try to identify novel autoantigens that could be related to type 1 diabetes. And for that purpose, we microarrayed a lot of different tissues, including pancreatic islets from an Enodema strain. We also looked at other strains. And we took advantage of this particular strain of mice because they develop spontaneously autoimmunity against the islets. In the course of these studies, we identified a novel autoantibody against a protein called serpin B13. So that finding in itself may not be that super exciting because people have described a lot of different autoantibodies, both in type 1 diabetes and other autoimmune conditions. But what we were able to find is that if you look at the natural history of diabetes in these mice, which is shown here, so these mice develop diabetes at different ages, less than 16 weeks of age, and then it continues. Some never develop diabetes. We found that there was a correlation between autoantibody to serpin B13, which, by the way, is present only in about 10 to 15% of the colony. So it was an infrequent finding, but nevertheless, this autoantibody was associated with delayed onset, suggesting some kind of a protective mechanism, which is kind of unusual for autoantibodies, which for the most part are associated with elevated risk, accelerated disease development. So following this observation in NOD mouse colony, we obviously became interested whether serpin is, this particular serpin is expressed in the pancreas. And for that, we stained the pancreas with antibodies to different antigens, including keratin. And we found that serpin and keratin merge. Here is an islet of from the mouse. So these islets usually stain with glucagon at the periphery. And here you can see that there are some intra-islet cells that stain for serpin B13, but most likely these are the ductal cells trapped inside the islet. And we confirmed that serpin B13 is expressed in the isolated ductal cells, but not in the exocrine tissue. There's a little bit of serpin signal in the islets, which may represent a contamination. So using two independent approaches, we were able to confirm that serpin is indeed expressed. So serpins are important protease inhibitors. Some common names for serpins are alpha-1 antitrypsin, C1 inhibitor, antithrombin, and these are extracellular serpins. The serpin B13 is a member of one of 8 clades, B clades specifically, which are intracellular serpins. And serpin B13 has been demonstrated in several papers to be an inhibitor of cathepsin K and L. It is expressed in several different tissues. It's not pancreatic specific. In fact, it was found in the brain, skin. It can be elevated in inflammatory lesions in the skin. Certain stimuli like UV and other forms of stress can promote expression. But it also, although it's intracellular, it has been found that it can function in the extracellular matrix to regulate angiogenesis in some in vitro models. This is a model to show you how serpins operate. These are interesting molecules which trap proteases through an active loop, and serpin with the protease form a docking complex, which is an inactive complex. There's a covalent bond formation, and molecules, these complexes undergo degradation. Sometimes serpins can form polymers, which also can lead to pathogenesis. So before we jumped into more mechanistic studies, trying to understand what autoimmunity to serpin B13 does or doesn't do, we performed several clinical translational studies to make sure that it is important findings. So I will go through these findings. The first translational study was done in collaboration with the Belgian Diabetes Registry and was based on looking at the age and sex-matched recent onset diabetics in healthy subjects. And we found that in control, there is a interesting high frequency of these antibodies in very young children, less than 5 years of age, and eventually this antibody disappears. So that finding in itself is interesting because it can tell us a little bit about what could be the reason for these autoantibodies to to be induced in the first place. It could be the disease of the young age, upper respiratory tract infections, skin cuts, etc. Injury to the tissues like plasma, like cells, mucosal membranes, or the skin where serpins are expressed. Could be an event that triggers a release of intracellular serpins and induction of autoimmunity against them. Once we grow up and we have less of these disease episodes, autoantibodies disappear. In contrast, in recent onset diabetics, at a very young age, young kids didn't have these antibodies or had much fewer. So there was this inverse correlation, which I thought was interesting. In the second study, we collaborated with the TrialNet consortium, and we took advantage of placebo samples from several clinical trials in type 1 diabetes, and we looked what happens with C-peptide, residual C-peptide after the onset in people who have antibody or don't. And we found that both fasting and stimulated C-peptide levels were elevated within the first year after diagnosis if you have antibody. For comparison purposes, I assembled data from Kevin Herald. The data are different because they looked at 4-hour meal stimulation, C-peptide release, and they looked at 24 months post-therapy with anti-CD3. We looked at 6 months after onset and 90 minutes. But the main message is the same, that if you use these antibodies, anti-CD3, or you have pre-existing anti-serpin B13, the C-peptide, residual C-peptide is about 2-fold higher. And finally, the last, I think the most interesting and important study, which we accomplished just recently, was done in collaboration with Diabetes Prevention Trial for type 1 diabetes. NADDK repository gave us the samples from people who were staged for elevated risk. For type 1 diabetes, we found that those folks who have elevated risk for type 1 diabetes and happened to have an autoantibody, they progress to diabetes, but at a much lower rate. So if you have an elevated risk determined by glucose intolerance or autoantibodies, other family history, a combination of these factors, your chances is about 50% over the next 5 to 7 years that you will have a diabetes. So this is a good cohort for clinical trials, prevention trials. But if you have an autoantibody to serpin B13, you drop by 20 points with your possibility of having diabetes. And this is also Kaplan-Meier's survival, which shows that there is a delay about 1 year. So we felt good about this data because, first of all, we confirmed that autoimmunity to serpin B13 is present not only in the mouse, but also it's a phenomenon that can be described in humans. More importantly, we found that autoantibody to serpin B13 is associated with improved outcome, which is kind of unusual for autoantibodies. Importantly, we also found that serpin B13 is expressed in the exocrine pancreas, which is yet another unusual feature because most diabetes-related antigens are confined to the islets. And here we go, we find serpin B13 in the exocrine pancreas. So it intrigues us how is it possible that autoimmunity directed against something that is outside the islets triggers changes in the islets possibly? Is there some kind of a crosstalk between exocrine and endocrine tissue? And from the literature and from our knowledge about how serpins operate, we speculated that probably this autoantibody is functional. And that's based also on other examples of other situations in medicine. So we know examples of autoantibodies against protease inhibitors or other molecules involved in the regulation of protease cascades that have functional impact. in acquired angioedema. In some of these patients, autoantibody can affect C1 esterase inhibitor, and that leads to activation of the complement. And in patients with membranoproliferative GN, and also in patients with C3 glomerulopathy, patients frequently have nephritic factor, which stabilizes convertases, which allows for consumption of complement and its deposition in the kidney, which leads to disease. Our model would be that in the presence of an autoantibody to serpin B13, you change the equilibrium, and instead of having inactive complex, actually you neutralize serpin in favor of rescued, at least partially rescued protease activity. So the proof of concept for that was obtained with our monoclonal antibody, which we developed in the laboratory. This monoclonal is specific for serpin B13, and when we added it to the pancreatic extract, we found that protease activity goes up. This is a control antibody, no effect. And then we repeated this in vivo by injecting animals with our monoclonal and using a probe against specific, using a specific probe against active cathepsin, which is protease target for serpin B13. And we found that protease activity goes up with our treatment, but only in the pancreas, but not in the liver, where serpin is not expressed very highly or not expressed at all. And importantly, the knockout mice were resistant to antibodies, since this cathepsin is a target for serpin B13. So in addition to a mouse monoclonal, the original mouse monoclonal that we have in the lab, we also have a humanized version of that antibody, and also we generated a completely 100% fully human monoclonal antibodies to serpin B13. We confirmed that they bind serpin B13, but not other serpins from clade B family. And we also wanted to make sure that they are functional. So this is an assay with fluorometer, where we follow up on the protease activity of cathepsin, and you can see that by adding increasing concentrations of serpin, you can completely almost block cathepsin activity. But if you combine it with serpin B13 antibody, actually you can rescue to almost normal levels activity of cathepsin L, and this seems to be specific because if you use just antibody alone with cathepsin L, the protease activity of cathepsin L doesn't go up. So over many years, we had this observation that mice, our original colony of NOD mice, that were in which some mice were positive for autoantibody, that these mice had more pancreatic islets. And that stimulated our efforts, which lasted several years in the lab, to perform some morphometric analysis of what's happening with the islet mass and the islets in mice with exposed to autoantibody to serpin B13 or injected with monoclonal. So under normal conditions, which are shown at the bottom here, islet mass basically is so in the mouse there are two types of islets: the large islets and small islets, and we used 200 micron in diameter as a cutoff. So anything that is more than 200 was considered to be a large islet. So if you think about islet mass, which is usually about 2 to 3 milligrams per pancreas in the mouse, most of that islet mass is due to large islets. The large islets account only for about 25% of all islets, 30% of islets, but they account for 75% of islet mass, where small islets are much more numerous, but they don't matter that much, at least in terms of the islet mass. So what we observed with longitudinal studies that lasted in mice almost a year, we found that initially when mice are treated with antibody to serpin B13, there is an increase in the small islets without change in the islet mass, but as time goes on, eventually you end up with more larger islets and increasing the islet mass. So this is all published. But because of these changes in the islet mass, we thought that perhaps something more interesting is happening with islet neogenesis during embryogenesis. And for that, we turned our attention to a molecule called NGN3, which is a master regulator or a transcriptional factor, which is responsible for determining the fate of the endocrine lineage in the developing pancreas. It's a transcription factor which regulates things like NeuroD1 and other transcription factors which are important for beta cells and alpha cells. It's a very interesting transcription factor, NGN3, because during embryogenesis in the pancreas of a mouse, it comes and goes. There's initial peak of NGN3, which is linked to generation of alpha cells. Then there is another larger, broader peak during mid-pregnancy, which is related to beta cells development, and eventually the last cells that show up are delta cells. So NGN3, when it is expressed usually for a short period of time. So sometimes when you perform experiments, it's hard to catch it. Nevertheless, we became interested in what happens with this marker of endocrine lineage in mice. And first of all, we confirmed that serpin is expressed during embryogenesis. Here you have treated acts highlighted with serpin staining, and we confirmed that by IF as an independent approach. And what we did, we obtained pregnant, healthy biopsy females, isolated from them pancreatic explants, and treated them in vitro with different reagents. So first of all, we treated these explants with chicken of albumin as a negative inactive serpin. We also use recombinant mouse and recombinant human serpin B13 and found that there is a drop in the number of NGN3 cells, whereas if you use our monoclone, it goes quite up. Not to mention, we also found that serpin B13 can be identified in the extracellular, in the supernatant of these cultures. And here is microscopic representation of the data. You can see we stain here the cells with NGN3 antibody, which shows nuclear crisp staining. We repeated the studies in vivo by injecting pregnant females. And again, we found that there is an expansion of NGN3 cells compared with IgG control. And because some of the reviewers questioned the quality of our antibodies that we used for NGN3, we confirmed that NGN3 is upregulated by Western blotting and also by flow cytometry. So I think we have an unequivocal evidence that NGN3 cells go up using 3 independent methods. Another important message here is that when we look at the pancreatic tissue, the exocrine tissue, the epithelium doesn't change in terms of the mass or area. So this is a process that is specific for inducing NGN3 cells. And another control that we obtained in the lab was a study in which we used different antibodies to serpin B13. So only our original clone B29, which stains the pancreas, induces NGN3 cells, whereas another clone B34, which fails for whatever reason to stain pancreas but does stain the skin, does not induce NGN3. So this data looked pretty, but we were not sure whether it means anything. In other words, do these NGN3 cells become insulin-producing cells? For that purpose, we took advantage of the lineage tracing approach in which we crossed NGN3 Cree mice with ROSA26 to label all NGN3 cells. We then stimulated mice with our antibody and counted how many of those green or yellow cells eventually acquire insulin, we found that there is about twofold increase in the number of insulin-positive cells arising from the NGN3 cells, and also that translates to increased islet mass, which in embryos can be measured by the islet area. And importantly, we were able to reproduce this finding in the setting of adult life. So here, the scheme is a little bit more difficult, more lengthy. So again, we took advantage of the same combination of the mice NGN3 rosa, YFP, and then we didn't sacrifice mice, but let them live, and then injected mice with streptozotocin at the age of 8 weeks, and we labeled them with, we injected them with the antibody, but also we injected them with tamoxifen to induce labeling, and we did it several times because, as I mentioned, NGN3 cells come and go, so you need to make sure that you label enough cells. And what we found was that if you have a healthy condition, under healthy conditions, it really doesn't matter. So there is no increase in the number of NGN3 cells that become insulin-positive cells, but under stress conditions of metabolic stress related to hyperglycemia induced with STZ, you have a jump in a number of insulin-positive cells, double positive cells, suggesting that there's a de novo formation of these cells, de novo formation of beta cells with our antibody. So NGN3 is regulated by an important pathway of Notch signaling, and we turned our attention to Notch as a proximal signal that may be affected by our therapy. And here is a simple model how it works. So first of all, Notch is a large molecule of about 300 kD, transmembrane membrane, and what happens, Notch binds to its ligand, the delta-4 or jagged, and then there's a cleavage following the ligand binding, the cleavage of Notch through gamma secretase, which is transmembrane molecule. And that allows for intracellular Notch active Notch domain to migrate to the nucleus. And through stimulation of expression of transcription factor Hes, NGN3 is kept low. So in other words, Notch pathway represses NGN3, and if Notch is not active or something happens to Notch, then this repressive mechanism is abolished, allowing for NGN3 to go high. So we looked at Notch by Western blot as our initial approach, and we took advantage of different antibodies. You can look at the extracellular domain and you can look at the intracellular domain. The extracellular domain is pretty high, it's about 250, and you can pretty much, this is intact Notch. So what you would expect that with the cleavage of extracellular domain, the signal goes down of the intact Notch, but at the same time you have induction of cleavage products. And this is intracellular Notch, so we looked at the level, the staining of the intracellular domain. Before we jumped to studies with our antibody, we first of all wanted to do a simpler experiment with recombinant catepsinel, which may sound a little bit weird because it's an enzyme which requires low pH, so you cannot stimulate explants for extended period of time because they will die, of course, in low pH. So we pulse them just for 4 hours. But with this short pulse, we noticed that pancreatic explants became very positive for NGN3. There was a stormy activity for NGN3 expression. And also we found that the Notch, intact Notch goes down, and there is a cleavage fragment. Or actually, there are several cleavage fragments. We then repeated this approach, repeated this experiment using our monoclonal antibody to serpin B13, and we've incubated explants with the antibody for either 24 hours or 48 hours, and you can see there is a gradual increase in the inhibition, in the cleavage of Notch. And we confirmed that again, we could observe the cleavage fragments of notch after treatment with antibody, and we were able also to show that staining of the extracellular domain of notch by flow goes down. So again, we used three independent approaches to look at notch. This is another approach where we looked at the intracellular domain. So it was important if we cleave the extracellular notch, doesn't matter for notch pathway, for notch signaling, and you monitor notch signaling by looking how much of active notch, intracellular domain notch is present, and we found by flow cytometry and Western that this notch signal, active notch, goes down with our treatment. Interestingly enough, we also found that there was no change in the expression level when we did PCR. So it appears that whatever we do to notch, it happens at the protein level, not at the gene expression level. And to conclude this part on proteases, we also employed protease inhibition using E64 protease inhibitor, and we found that the cleavage of notch, which occurs in the antibody, occurs no more if you use at the same time protease inhibitor. Here, there are studies showing that if you use E64 inhibitor, you drop the number of NGN3 cells. And also we employed cathepsin L knockout to show that if you lack cathepsin L, the number of NGN3 goes down, and also cathepsin L knockout are insensitive to therapy, to treatment with SERPINB13 in terms of NGN3 cell output. So with these studies, we wondered in the next phase, does it matter if we generate this, we induce cleavage of notch, we generate new NGN3 cells, we generate new beta cells during embryogenesis, but does it matter after birth when mice grow up? And for that, we looked at adult pancreases. We froze them into the blocks, we cut them serially, stained for beta cells with anti-insulin antibody, and took advantage of the Visiopharm software to calculate number of islets and islet mass and other things. This is an example of such analysis where mice were first exposed to antibody therapy during embryogenesis, and then we looked at them many weeks later after birth, and we found that first of all, the number of islets is elevated, and also the islet numbers is increased. Another important piece is that alpha cells also were upregulated. So it seems that whatever we do in the endocrine pancreas affects both lineages, both beta cells and alpha cells, which makes perfect sense because we deal with NGN3, which is a master regulator for other lineages as well. And when we repeat this experiment, but this time it used diabetes, under these conditions, the residual beta cells mass was increased, and glucose levels, glucose control at random was improved. And overall severity of diabetes was improved as well. And under control conditions, usually with the dose of STZ that we use, which was specifically 150 milligram per kilogram, this mice, about 50% of them developed severe diabetes, which is over 600 milligram blood glucose, and all of them, there were no non-diabetic mice. So we have 100% effect. In SERPIN antibody-treated mice, there was no mice with severe diabetes, and up to 1/3 was completely diabetes-free. Not to mention that the kidney function was improved as well. The body mass weights, pancreatic weights were pretty much intact before treatment, and during therapy, the body was better maintained following diabetes induction in treated group. So with these mouse studies, we wanted to ask yet another question. Okay, so we know about the mouse, but how about humans? We did some translational studies, but the key thing for us was to understand whether the autoantibodies to SERPINB13 or if they are functional. So this is the picture which I showed you before. So first, the first approach to address this problem was to take advantage of human monoclonal antibodies that we generated in the lab. These are not perhaps natural autoantibodies, but can be used as a starter. So we found that this in a biochemistry in the tube that these antibodies are functional, they rescue calypsinol activity. But when we used our pancreatic mouse pancreatic explant as a model, as a readout for NGN3 cells, we found that these antibodies increase, that the monoclonal antibodies increase number of NGN3 cells. But our reviewers wanted a proof about the autoantibodies that they are functional. So for that purpose, we performed an immunodepletion experiment, and we took both negative serum samples from DPT cohort and positive serum samples from DPT cohort. In the negative samples, it really didn't matter whether you immunodepleted or not, but for the positive ones, the number of NGN3 cells dropped down after immunodepletions. And the final experiment consisted of using purified autoantibodies. So first we used semi-purification. We just dialyzed samples, and we found that positive samples gave us a boost in the number of NGN3 cells. But more importantly, when we did affinity purification of autoantibodies from positive samples, there was also a positive impact on NGN3 cells. So this data with the monoclonal antibody and with purified autoantibodies are very similar to each other. So this is our model. We think is that with the secretion or passive release of serpin and catepsin, if you happen to have an autoantibody or a monoclonal antibody to serpin that allows catepsin or potentially another proteases to cut and cleave notch, and that disengage notch and allows NGN3 cells to be active and form beta cells, and that gives you advantage and resistance to severe diabetes. However, so you can think about notch pathway as a gatekeeper that keeps progenitor cells or stem cells in other tissues at bay in a quiescent fashion. And when you disengage, if you remove this repressive mechanism, then you can stimulate progenitor cells in the tissues for regeneration or de novo formation of tissues. And because notch pathway is present, is expressed, as well as serpins are expressed in different tissues, we have no reason to believe that what we have described for NGN3 cells in diabetes is just an isolated finding. So we would like to speculate that we can extrapolate our findings to other disease models and other tissues and situations. This is just my last slide. And we have tried several different models so far. These are quite preliminary data. We looked at the bone fracture. So notch pathways is quite important for developmental biology in the bone, but also during healing from the fracture. Here we use a tibia fractured model, and we found that the therapy with serpin antibody accelerates healing. You can see a callus formation here, which is pretty significant. We also looked at the skin ulcerated lesions. Skin also is quite positive for serpins. And in this model, we used complement adjuvant to stimulate inflammation and nasty-looking skin lesions, which were healing or prevented with our therapy. We also looked at the CNS inflammation using a model of experimental autoimmune encephalomyelitis, and these mice, when were treated with serpin antibodies, showed a lower death rate and also lower paralysis rates. They were observed in these animals. And most recently, since notch is expressed in the, and serpin is expressed in the thymus, we became interested in the thymocyte developments as well. So these are the people that contributed to this work. Foremost, I would like to acknowledge people, past and present members of my lab. Yuri Krivalap is a postdoc in my lab, and he has done most of the work that I talked to you about on the Notch and GN3. Octavian Henegario was my colleague who helped me to make original observations on SERPIN autoantibody, and other faculty at Yale were supportive of these efforts. Several consortia played critical role in executing translational studies. And more recently, I started to develop collaboration with people in our university. Foremost, I would like to acknowledge Dr. Chris Hawkins, who helped us to do some early timing studies. Hopefully, we'll be able to do more work. I also am in the process of developing collaboration with Patrick O'Connor on bone fractures he's at Rutgers, New Jersey Medical School, and folks at the Office Technology, in the Office of Technology Commercialization, are helping me with technology development for the humanized SERPIN antibody, and these are our sources of funding. Thank you.
Thank you, Jan. Now we see if any questions for Jan.
May I please ask a question? Dr. Czyzzyk, this is Dr. Dayton from Hematopathology. Has anyone looked at anti-SERPIN antibody levels during the course of pregnancy in human females?
So
and
this is
looked at pregnancy outcomes and
yes,
because I'm sorry, the reason I'm asking is I've been following what you're explaining closely. I've always wondered about the male to female ratio in type 1 diabetes is 2 to 1. And for virtually every other autoimmune disorder, it's female predominance. And that's always intrigued me. And I'm just wondering if maybe the answer is somewhere in anti-SERPIN antibody levels as a functional part of human pregnancy. And I will mute myself. Thank you.
Yeah, so thank you very much for this question. This is a great question. We've been thinking about it for quite some time, and actually even, so I guess we approached it from diabetes type 1 angle, and we approached India consortium in Australia to obtain samples from pregnant females that have diabetes or at risk for diabetes, and this is like a follow-up study. And they are still in the process of waiting for children to be born and reach certain age to have enough material and samples. So we are in the process of awaiting, but yes, the direct translation of the studies that we have made on the pregnant mice would be to look, what happens with pregnancies in humans. Do women that have autoantibodies to SERPIN, do their children, I mean, if this is somebody who has diabetes type 1 or at risk, their children by definition will have elevated risk. But the question is, if you have that autoantibody, will this risk change? Will it go up or down? We would predict it would go down, but of course, we don't know that for sure. So we've been in communication with these people, and we are still waiting for early 2022-23, where there will be enough, material based on our power analysis. We need to have about 60 to 100 subjects at least to examine that.
But have uncomplicated women with uncomplicated pregnancies, women with no family history, no history of autoimmunity or diabetes, have they had blood samples collected throughout the course of pregnancy to determine whether or not anti-SERPIN antibodies are a normal functional part of human pregnancy? Right. That's a question.
So of course, that's also a very good comment, and but we haven't looked at it. And I'm not aware that anybody else has.
Wow, maybe, hey, that could be your next Nobel Prize. Okay, sorry, I'll mute myself.
Sounds great, thank you.
Yeah, this is Deleuze. I have a quick question. That was nice. Have you looked at the effect of cathepsin L itself in reproducing this. So cathepsin L is downstream to the serpin B13, right, from your model. So
Yes.
what happens when you inhibit cathepsin L? Are you able to recreate the same?
Yes, so I think maybe I just run through this data very fast. So cathepsin knockout mice have fewer NGN3 cells, so it can it works in the model because by inhibiting serpin we improve protease activity and that increases number of NGN3 cells. But if you remove protease from equation, either with protease inhibitor or the genetic approach with the knockout, you downregulate number of NGN3 cells, so it works in the opposite direction.
Yeah, I'm just wondering that mice without antibody or any other upstream intervention, that you just take out cathepsin L itself, whether
Yes.
that would increase.
So this mice, that's a good question. So these mice, as I mentioned, they have fewer NGN3 cells, but when we looked at the islet mass, they didn't have much change in the islet mass. And it could be that these studies were not thorough enough, but then also could be that there are other proteases which compensate over time. There's also cathepsin K, which for the most part is expressed in the bone, but also may be expressed in some levels, and then maybe in the pancreas. Not to mention there may be some other protease targets. So if you remove one enzyme, one protease, it's always possibility for compensation by other proteases. But to answer your question directly, we have not been able to observe decline in the islet mass with lack of cathepsin in the mice.
And one other quick question, if I could, is there any difference in the acinar cell of the pancreas in this? The reason why I'm asking is in the liver cells, you know that when you inhibit cathepsin L, it favors hepatocellular regeneration. So I'm just wondering whether the introduction of anti-serpin B13 antibody has any impact on the acinar cells.
So when we looked at the expression of serpin, we found it specifically to be confined to the ductal cells. We didn't find anything in the acinar cells. Having said that, one comment I can share with you is that acinar cells, according to some studies, can be the source of transdifferentiation to become beta cells. But in our lineage tracing studies, we haven't been able to confirm these findings.
Thank you.
We might still have time for a quick question.
Yeah, this is John Crossan. Jan, I couldn't help but think about the fact that you also work with another cell that generally does not regenerate itself when it's injured, and that is the podocyte in the glomerulus. However, there is a disease state, as you know, that does result from excessive regeneration and proliferation of the podocytes, and that, of course, is collapsing glomerulopathy, which often is due to a viral infection, but the virus does not directly infect the podocyte, but in some way it probably alters the genetic makeup of that podocyte so it can regenerate. Is there anything in the podocyte regeneration and collapsing glomerulopathy that you can transfer to your work on beta cells?
Yeah, so when we identified serpin antibody, I became immediately interested in the profile of its expression in the kidney, and I couldn't find any convincing signal in the glomerulus or another part. Really? But as I mentioned, this is just one of the members, so there are another 10 serpin clade B serpins. So, and some of them also express cathepsin L. Target cathepsin L. So one serpin can block different proteases. One protease can be blocked by more than just one serpin. So there's certain overlap, which I think makes sense. So I think you're making correct point. It would be at some point good to look at the expression of other serpin molecules to make an atlas of kidney to see what is expressed there, what is not.
Yeah. Thanks.
Thank you.
Well, thank you, Jan, for the very stimulating
Thank you very much.
presentation. And obviously, it's stimulated lots of questions and lots of comments. Very interesting. We thank you all for attending
Thank you.
webinars today, and look forward to seeing you again next week. Thank you.
Thank
Thank
you.
you all. Have a good day.